Welcome to the ADA's podcast, Diabetes, Obesity, and Cardiometabolic Disease podcast, formerly known as Diabetes Core Update. And as people may or may not remember, we have renamed this podcast as of the 2026 ADA scientific sessions to more accurately reflect what we actually now cover. I'm Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College, and joining me, as always, is my great co-host.
I'm John Russell. I'm clinical professor of family and community medicine at the Sidney Kimmel Medical College and chair of family medicine at Jefferson Abington Hospital.
And John, we have another great set of articles this week covering a range of things, beginning with an article from Lancet Diabetes and Endocrinology on the efficacy and safety of once-weekly CagriSema semaglutide, that is CagriSema, in adults with type 2 diabetes inadequately controlled on diet and exercise, the Reimagine 1 trial. Then we're going to talk about an article from the Lancet on the efficacy and safety of retatrutide, the famous triple G, a GIP, GLP-1, and glucagon receptor agonist in people with type 2 diabetes and inadequate glycemic control with diet and exercise. And that is the Transcend T2D #1 study. That is a phase 3 trial. Then we're going to talk about a presentation at the 2026 ADA scientific sessions on the CONNECT trial, CONNECT CGM, in non-insulin using people with type 2 diabetes. Then from Nature Medicine, orforglipron for maintenance of body weight reduction, the double-blind randomized phase 3B Attain Maintain trial. And finally, we will discuss a personal favorite of mine from JAMA, lifestyle and metformin interventions and risk of multimorbidity in adults with pre-diabetes, a pretty phenomenal long-term follow-up trial. But let's now jump in. And from the Lancet Diabetes and Endocrinology journal, where the title of our first article is Efficacy and Safety of Once-Weekly CagriSema semaglutide, that is CagriSema, in adults with type 2 diabetes inadequately controlled on diet and exercise. The Reimagine 1 trial, a randomized double-blind placebo-controlled phase 3A study. Background here is CagriSema semaglutide, or CagriSema, is a novel once-weekly combination of the amylin receptor agonist, CagriSema, and the GLP-1 receptor agonist, semaglutide. The authors aim to assess the efficacy and safety of CagriSema for people with type 2 diabetes inadequately controlled with diet and exercise. Reimagine 1 was a randomized, double-blind, parallel group phase 3A study where people were randomized to 2.4 milligrams of each of the medications, 1 milligram of both CagriSema and semaglutide, or a placebo group. The primary endpoint was a change in A1C from baseline to week 40. Change in body weight from baseline to week 40 was a pre-specified secondary endpoint. There were 189 people who were enrolled. Baseline mean A1C was 7.8% and BMI was 35. Using the efficacy estimate, the estimated mean change in A1C after 40 weeks was a drop of 1.8 percentage points with CagriSema, semaglutide, 2.4 milligrams each, a drop of 1.5% with CagriSema, semaglutide, 1 milligram each, and a drop of 0.1% in the group with placebo. CagriSema was superior to placebo with respect to estimated mean relative change in body weight from baseline to week 40. For CagriSema 2.4, that was a drop of almost 14% versus placebo, which is a decrease in weight of 1.4%. Most adverse events were mild or moderate and GI related. John?
So fascinating little article, and I think there's a lot of things to unpack. So what the heck's amylin, right? So I think there are people who, of course, this has been around for 20 years. It's a 37 peptide hormone, also produced by the beta cells. And so it's been around for 20 years, and I don't think we've completely kind of found out where it fits in. So what does it do? Well, it does a lot of the things that we are asking for our medicines for weight loss in this category. So it is affecting the satiety centers. It is decreasing glucagon, so you're not having so much glycemic release from the liver. It is slowing gastric emptying. I think that all sounds pretty terrific. Also has some effect on the bones. Separate talk, different day. So it has kind of been that other hormone besides insulin, secreted with insulin, gets depleted in people who have type 1 diabetes. So certainly it is physiologically something. Hey, let's start replacing something that we have. So interestingly, to combine this with one of our weight loss / diabetes GLP-1s to kind of see, if there's an additive effect. What I think is interesting in this study is all the people in this study had diabetes. I think the average was 1.4 years. So not a lot of some of our other studies where we have people that have travailed everything under the sun for diabetes and then kind of find themselves in one of these studies with a lot of potent medicines. And the level of diabetes that the patients had on average was pretty modest, A1Cs in that upper sevens. So looking at the three arms, the higher strength for both did better, not a ton better, but did a better than the middle dose for both of them, and certainly did a lot better than placebo. And when you look at the end of the day, depending on which dose, you're getting in that 1.6, 1.8 difference in A1C reduction and about that 12 to 13% difference in weight loss at 40 weeks. So, one of the things I would have loved to have seen, a semaglutide arm, but I think we could kind of dive into the literature and say, well, just using monotherapy with the semaglutides probably getting you in that 1.6%. So when we look at the studies of semaglutide in people with obesity and diabetes, the weight loss lives in around that 10% range in the studies. So the interesting thing is, did the amylin help preserve beta cell function? And they did a lot of markers along those lines in this study, with the possibility that maybe, and certainly by the time someone starts having some abnormal sugars, they've lost 50% of their beta cells. By the time we're starting medicines, they've probably lost about 80% of their beta cells if they have type 2 diabetes. So I think that that's an interesting thing. So perhaps this peptide that's been kind of hanging around for 20 years, maybe it's found a home in pairing with a GLP-1. Certainly, it's nice to see that this is paired with a weekly medication and not shoehorned into something that's an everyday injection. So I think it's interesting, but when we're talking about legacy effect, and we're going to talk about that later, getting people fixed early probably has a huge impact on what happens later. And our real role is not just the hyperglycemia now, it's really preventing microvascular and hopefully some macrovascular disease down the road. And if this can be a very set it and forget it early diabetes, we put someone on this, someone who is overweight, that they can lose weight, that they can get their A1C to goal, and really had a nice percentage of people who kind of fell out of, they got their A1C below the threshold for diabetes. really could be a magnificent thing. And hopefully, maybe we'll see later that it does prevent a lot of mischief that might happen 15, 20 years down the road. Our next article is from The Lancet, and it looked at efficacy and safety of retatrutide, a GIP, GLP-1, and glucagon receptor agonist in patients with type 2 diabetes and inadequate glycemic control with diet and exercise. So this was the Transcend T2D1 study. So this was a 40-week phase 3 randomized double-blind placebo-controlled trial that happened at 48 states in the United States, Mexico, and India. They recruited adult patients with type 2 diabetes who were inadequately controlled by diet and exercise alone. They had to have an A1C between 7 and 9.5 and a BMI of at least 23. The participants were randomized 1-to-1 to 1-to-1 to receive retatrutide, either 4 milligrams, 9 milligrams, or 12 milligrams, or placebo by once weekly subcutaneous injection. The primary endpoint was a change in A1C concentration from baseline to week 40. A secondary endpoint was a percentage change in body weight from baseline to week 40. So between April 2024 and April 2025, there were 930 participants screened, 537 were female, which would be 55%, 45% then were male, were randomized to either 134 being in the 4 milligram, 133 being in the 9 milligram, and 136 being in the 12 milligram retatrutide arms, and 134 in placebo. The baseline mean age was 48.8. The mean A1C reduction was 7.9. The length of the time that they had diabetes was 2.5 years, and the mean BMI was 35.8. The mean change from baseline in A1C concentration was 1.69 for the 4 milligram dose, 1.86 for the 9 milligram dose, and 1.94 with the 12 milligram dose. There was a decrease of 0.81 in the placebo group. So the treatment differences, therefore, would have been a decrease in 0.88 from the 4 milligram retatrutide dose, a decrease 1.04 the 9 milligram, and 1.12 with the 12 milligram dose. The mean percentage change from baseline in body weight was a decrease in 11.5 with the 4 milligram, 13.9 with the 9 milligram, and 15.3 with the 12 milligram, versus a decrease in 2.6 with placebo. The most frequent adverse events with retatrutide were generally mild to moderate GI effects, which subsided over time. The study intervention discontinuation due to adverse effects was 2 to 5% with the retatrutide and 0% with placebo. There was no severe hypoglycemia reported. 2 deaths occurred in the study, both in the retatrutide 4 milligram dose group, and they were unrelated to the study drug.
John, we've been waiting for the retatrutide results in both diabetes and weight loss for a while. I think this is a medicine everyone's been very excited about, nicknamed the triple G for being a GIP, GLP-1, and glucagon receptor agonist. What I'd like to do is talk first about briefly what glucagon adds, then we'll talk about this study, and then I'll touch on the Triumph program, which was the data was shared at the ADA scientific sessions. I was there a few weeks ago. It was very exciting. It's not yet in print, which is why we didn't cover it today. We will when it's published. So first of all, the glucagon receptor agonist. What glucagon adds is it appears to increase energy expenditure, which none of our other molecules have yet touched on. It also, like our GLP-1s and GIP-1, suppresses appetite. It also enhances fat metabolism. So it fits into our general approach for glycemic control as well as weight management. When we look at this article, for diabetes, it's it's a powerful, powerful agent, unequivocally. You have a drop of almost 2% in A1C. It's roughly in the same range as we saw with tirzepatide in the SURPASS programs. as well as its weight loss in people with diabetes, is roughly in the same range as we have in the SURPASS programs with tirzepatide. That is nothing to sneeze at. That is very powerful. And in fact, when we talk about people entering studies, there probably becomes a cap at about 2% drop, how low you're going to go, because with all of our medicines that don't cause hypoglycemia, we we see less effect the lower the A1C is. So that's actually a good thing. Let me now go over, almost as a teaser for when the articles come out, some of the information that was presented at ADA in the data reveal of the Triumph study. And this was a phase 3 double-blind randomized trial of retatrutide, the triple agonist, for obesity in people without diabetes for weight control. And at the end of the 80-week trial, there was 28% weight loss. And what was amazing, so that's 70 pounds. They did a pre-specified extension study to 104 weeks, and there was over 30%. It was 30.3% weight reduction, a weight loss on the average of 85 pounds in the people in that study. The study was an unusual one because it included what is called a bucket design, meaning they included people specifically with knee osteoarthritis that they followed, and included people with OSA, obstructive sleep apnea, that they followed in buckets. And in those two buckets, there was important improvement in pain for the people with knee osteoarthritis. I don't think that's surprising. And there was actually a 60% decrease in the apnea hypopnea index, so more than we saw in the tirzepatide OSA study for people with obstructive sleep apnea. So, in summary, we see retatrutide as a very powerful glucose lowering agent in people with diabetes, and an incredibly powerful medicine for weight reduction, as well as knee arthritis and OSA in people with obesity. We will talk more about this when the articles are studied. Our next article, I think, is really a fascinating one, and I'll correct myself, it's not an article. It is data that was presented at the scientific sessions, and this is the CONNECT study in people with type 2 diabetes. Here, study participants, all of the study participants here were provided with diabetes education on diet and exercise at the start of the study, and the active group were given the Dexcom G7 continuous CGM. The other people in the study used self-monitoring of blood glucose. Interestingly, this was conducted at 22 primary care practices. So this was non-specialty primary care, which is where most people with type 2 diabetes not on insulin are seen. There were 283 eligible participants randomized to Dexcom G7 or routine care, with 265 people completing the 26-week study and analyzed for the important outcomes. What it showed, there was an average of 1.6% in A1C reduction with Dexcom G7 from a baseline mean A1C of 8.8%. Participants using the Dexcom G7 experienced an average of that 1.6% A1C reduction at 26 weeks, which was 0.9% greater reduction compared to the control group. Those who were randomized to the G7, who had an initial A1C greater than 10%, experienced an average of 3.1% A1C reduction, which represented a 2.1% greater A1C reduction than was seen in the control group. John?
So they probably should call this study the Knowledge is Power study. And we live in a world, and you and I working in primary care, of people coming in with wristwatch devices that are saying that they were in atrial fibrillation, or that they didn't get enough sleep, or etc. And this is certainly one of the things, one of the chronic diseases that we kind of deal with more on a micro level in our office, and a macro level as a nation, is dealing with people who have elevated blood sugars. And this really shows that people who are getting that continuous feedback loop could suddenly say, hey, I just ate this candy bar and my sugars are really horrible, or I think I'm eating this really healthy lunch and my postprandial sugars are very, very high. um, it really seems like a false premise anymore to think that people are going to be doing kind of Lancets on their fingertips more than rarely. And I think we've got a great technology, and certainly someone who's on insulin who is at risk for having hypoglycemia, certainly at risk for all of the complications in trying to lower these sugars, certainly should be on these. And we've looked at a ton of these studies of everyone who has DKA who leaves the hospital, et cetera. So this study's not looking at that population. This study is looking at a kind of a primary care population, people with type 2 diabetes, who don't necessarily need, safety wise, for whatever treatment they're getting, to have that. And if you looked at kind of older guidelines for who should be doing self-monitoring blood glucose, it's not clear that everyone with type 2 diabetes who fits into that category needs this. But if you're looking at the long game, and you can get people's A1C reductions this much by just having them have some more knowledge on their sugars, to qualify to the FDA as a medicine for diabetes, the expectation is you're going to have at least a 0.5% reduction in A1C. Certainly triumphed that just by people knowing. So I think, as a nation, we're going to have to start playing the long game again if we can make a difference earlier, right? And these are these people who are starting to lay down some of the foundation for that microvascular disease. If you can make a difference just by people knowing, just by having someone wear something, and not everyone's going to want to, and not everyone is going to like this technology, and some people take great comfort in not knowing. But for the people who want to know, it certainly seems like that this should be part of what we're doing. Our next article is from Nature Medicine, and it looked at orforglipron for maintenance of body weight reduction, the double-blind randomized phase 3B maintain trial. So this was a double-blind placebo-controlled randomized trial where participants were previously treated with either tirzepatide, at 200 people in that arm, or semaglutide, about 170 people in that arm, during the SURMOUNT-5 study. They were randomized to orforglipron once daily or placebo. The cohort 1 participants who achieved body weight plateau maintained a model-based estimate of 74.7% of body weight reduction with orforglipron, compared with that of 49.2% with placebo, resulting in an estimated treatment difference of a little over 25%. By week 52, cohort 2 participants who achieved body weight plateau maintained 79.3% of body weight reduction with orforglipron, compared with 37.6% with placebo, with an estimated treatment difference of 41.7% at week 52. All the key secondary endpoints were met. The most common adverse events were GI effects, were mostly mild to moderate in severity. These data demonstrate orforglipron's potential as a globally scalable option for minimizing weight changes after the initial injectable therapy. The trial limitations include the absence of a comparator arm involving continued use of the injectable obesity management medications, and the trial's 1-year duration. Neil?
John, I love this trial because this is actually what we're all struggling with right now, to figure out what to do for our patients who have lost a substantial amount of weight on tirzepatide or semaglutide, And they've been on the medicines now anywhere from 1 to 2 to 3 years. And the question arises, do we need to keep people on the same dose of an injectable medicine that got them to that weight? Or what are the options? Now, the options are obvious. They're you either keep someone at the same dose, you wean down to a lower dose of the same medicine, because some people do still have some side effects on that high dose that got them there. Can people come off of the medicine? Well, we've seen trials that show that people in general will regain weight as they withdraw the medicine. Or are there other options? And now this is looking at an oral option. I know many of my patients don't particularly want to stay on an injectable forever. So the trial answers, or addresses at least, an important question that we're all struggling with. Couple of thoughts about this trial. One, very clear, orforglipron helped maintain a higher degree of the weight that was lost than having someone wean the medicine off completely. And in fact, when you look at the details of the trial, you also realize that the difference between orforglipron and placebo is significantly greater than the results show, because they had a rescue part of their protocol, which is if people were on placebo and they regained more than half of the weight that they had lost, they received rescue therapy with that 50% loss carried forward as their final results. So actually 60% of the people in the placebo group received rescue therapy. So orforglipron did much greater. It maintains more of the weight loss with an agent that didn't have as much initial weight loss, semaglutide, than it does on an agent with more initial weight loss, tirzepatide. Either case, a reasonable choice for maintenance. The other important thing that this trial addressed was, if we're switching medicines, do we need to go all the way back down to that initial lowest dose that we would do if we're starting the medicine anew? And the answer here is you don't. They started the medicine at the 9 milligram dose, which is important because that's a few steps up in the usual dose titration. And that lets us know if we decide to transition from whatever injectable someone is on to orforglipron, we can start at that 9 milligram dose and minimize the amount of time that someone's experiencing what would likely then be a lot of food noise and increase in appetite. So again, I thought this was a great trial, very informative, addressing an area that really is the new frontier for us, which is weight maintenance. And for our final article now, an article from JAMA titled Lifestyle and Metformin Interventions and Risk of Multimorbidity in Adults with Prediabetes. The goal of this trial was to examine the association of lifestyle or metformin compared with placebo on long-term multimorbidity in adults with prediabetes. This is an observational follow-up cohort study of one of my favorite trials of all time, a randomized clinical trial conducted at 27 sites in the United States way back, beginning in 1996 and following people all the way up until 2021. For the years of 1996 to 1999, over 3,000 adults at high risk of diabetes, so prediabetes, were enrolled in the 3-year Diabetes Prevention Program trial, the DPP trial, and they were subsequently enrolled in the DPP outcome study, and that was the follow-up study, DPP OS. And they were followed for a long time here. Data were analyzed from 2024 to 2025. CMS morbidity data were available through 2021 for over 1,100 participants who had provided consent for doing so. The participants in DPP were randomly assigned to either intensive lifestyle interventions with a lot of counseling and encouragement to do that. A lot of them actually did that intensive lifestyle, versus metformin 850 BID or a placebo. During the follow-up study, medications were unmasked with discontinuation of placebo, and that group was given metformin. The main outcomes here, where they looked at the primary outcome, was something that they called multimorbidity, presence of greater than 2 of 15 prevalent conditions. That was defined by a CMS chronic condition data set. Those 15 conditions were, I'm going to go through them quickly: hypertension, heart failure, coronary artery disease, arrhythmias, hyperlipidemia, stroke, arthritis, asthma, cancer, CKD, COPD, dementia, depression, diabetes, and osteoporosis. So a whole bundle of potential comorbidities, of which actually in follow-up, most people had some of this. Not a surprise. The median age at follow-up was 74 years, 68% were female. 85% in total experienced greater than or equal to 2 conditions. The median was actually 5 conditions by the end of follow-up. By the end of follow-up, 82%, 85%, and 87% respectively had more than 2 conditions in the lifestyle, metformin, and placebo groups respectively. So again, that's 82, 85, and 87%. The risk of comorbidity was lower among the lifestyle group compared with placebo participants, and after adjustment for relevant covariates, the hazard ratio was 0.79, so about 20% less comorbidities, people having more than 2 comorbidities in the lifestyle versus placebo group. There was no difference between metformin and placebo. When restricted to the dyads of the costliest condition, the association with lifestyle versus placebo yielded a hazard ratio of 0.57, or to say it a different way, a 43% decrease when we talk about the most costly conditions. John, all yours.
So Neil, knowing you for 37 years, I know this is probably your favorite study. I often encourage young people to bring this up to you, to bring joy to you. So, and for a podcast that we talk a lot about medications, kind of the antithesis, right? So we've talked today about people with early diabetes, and maybe instead of, and prediabetes in this case, instead of reaching for our prescription pad, maybe people really taking that long, hard look at what they're doing and what they could do better. And it made a huge difference. The old adage, give a man a fish, he eats for a day; teach a man to fish, he eats for a lifetime. But I think an even better adage is, in 1991, Cher had a VHS fitness tape that had come out for exercise. And she said, fitness, if good bodies came in a pill, everyone would have one. And that's kind of the truth, right? It's not simply about doing that. And again, it's not just diabetes, because in this particular study, they kind of pulled out some of the diabetes data, and people were less likely to have kidney disease, less likely to have heart disease, less likely to have hypertension, just by making some differences early. It's a lot of work, and I think we need to figure out some things kind of structured as a society, also playing that long game. If we have people who are young enough and fit enough to participate in this, that maybe we need to say, hey, let me tuck you into this kind of 2-3 year program that maybe will kind of change your outcomes in the future. But I'm thrilled for you that this still holds up kind of 30 years later.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.